I'm from Jacoby. We're going to talk about pediatric seizures, and we're going to do it fast. The definition of seizure, we're going to do this quickly, all right? Disorder of cerebral function characterized several brief attacks, altered consciousness, motor activity, sensory. This is a lot, okay? I like this guy, Justice Stewart. He was simple. When they asked him what pornography was, he says, I know it when I see it. And that's basically what seizures are, right? We'll know it when we see it. And we've all been stuck with this one, right? The teenager who comes in, quote unquote, seizing, the pseudo seizure. This is our problem in the ED. They cause a lot of heartache, hospitalization, and workups. So here's the idea. When you see them, if their eyes are closed and they're seizing and you don't think it's true, they probably do not have a seizure. They're not having a seizure, all right? They actually did video studies. They keep their eyes closed. People who have seizures keep their eyes open. So keep that in mind. I know we all dropped the hand on their face, but okay. We're talking about seizures because you're going to see them. Between 4 and 6% of children will have a seizure before they are 16 years of age, okay? To everyone who has children, I just made you worry. This is what worries us in the ED, status, right? Status is any seizures lasting more than 30 minutes. Now, there's a push to make that any seizure lasting in 5 minutes, right? Because they're starting to realize that 30 minutes is a long time. And in my day, we used to watch them seize. I was told to tell you, don't watch them seize anymore. So if the seizure is lasting between 5 and 10 minutes, then you need to do that because they will not stop on their own. Okay, let's go straight to treatment. It's the basics, so we go to fundamentals. Don't forget your ABCs. These kids will breathe very shallowly. You do not need to overbag them, so be careful with that, okay? Make sure you have airway, everything ready, and make sure you can try to get an IV. It's very difficult sometimes. That brings us to drugs, very simply. First line is always what? Benzos, right? We're going to start with our benzos. They're the first line in almost any seizure, all right? We start with lorazepam. It has the most potent. It binds the best to the GABA receptors, so it does work the best. That's followed by diazepam. We all like that because in the field they give a PR dose, but we'll talk about that later. That's followed by the second line, which is usually fosphenytoin or phenytoin. Valproic acid comes up next, all right? Phenobarb, still used in the neonatal period, okay? Kids less than 28 days, think about phenobarb if you have seizures. All right, but remember with phenobarb and the second line, they're always a slower onset. So they're gonna raise your stress factor. Labs, do we need to do labs? Here's real simple. If the kid's less than 6 months and you're not sure, do the labs. Do your electrolytes, do a calcium. Everybody should do a glucose, okay? It's funny, they've done studies where people don't do glucose on kids who seize. The neonates and less than 6 months, you're going to more likely to find the hyponatremia that's causing the seizure because someone's been, watering down the formula. Do we need to do a CT scan? That depends, but most of the time you do not. Kids has an afebrile seizure that's short, you do not need to scan his head, okay? If he's got anything else where he's in a high-risk category, he's got a VP shunt, he had head injury, do your scan. Okay, let's get back to drugs real quick. I'm trying to make a push for midazolam intranasally. I own no stock in it versus diazepam PR, okay? Diazepam has the longest history. We've been using it forever, 20 years now. It can be used IV, PR, ET. It is uncomfortable, okay, to the patient, though they're seizing at the time, but it's very uncomfortable for the person who has to give it, and it's very difficult, okay? Diazepam has a first pass through the liver. So a lot of the drug is not available to the CNS immediately, and it does stack up. And after a while, those kids come in with respiratory depression. And we've all got these kids who've gotten it in the field, and they're slogged for hours in the ED. And it can be expensive. All right? Intranasal midazolam, it's used with an atomizer, okay? Goes into the nose. And it goes into the nose because it's a very vascular mucosal area. And it gets directly absorbed into the bloodstream. Thus, it doesn't have to go through the liver. So it gets almost an immediate effect, okay? And it's cheap, all right? This group, they used intranasal midazolam on pediatric seizures in the pre-hospital setting. They found a decrease in total seizure time, a decrease in the recurrence of the seizures in the ED, a decrease in respiratory depression, which is our problem with, and then we had a decrease in hospital stay and admission, all right? Okay, I know this is the group that terrifies you guys, especially the EM group. They're small, they're wrinkled, they don't talk. Not much different than this group. That terrifies me. All right? So we'll talk a little bit about neonatal seizures. All right? Here's what you got to remember. They're subtle. Okay? Remember that. They are subtle. These kids will do something as simple as lip smacking, blinking, twitches, and tongue thrusting. Okay? And this is because they have very few inhibitory neurons at the time. So these reactions are typical of neonates. All right? Remember, subtle. All right? Because they're subtle, you have to talk to the mom. And not all the moms are going to look like her, but you have to listen to the mom, okay? She actually knows the baby. She's looking at this baby. She tells you there's something different and there's something wrong. You got to believe her. All right? A lot of times they'll be nice enough to bring you a video, which is great. Okay? They'll videotape these kids. All right. So basically, this was going to show you how subtle the seizures are. Basically, the baby's hand movements are very subtle. He'll have small grimaces, raise the corner of his mouth a little bit. Okay? And sometimes the kids will come in and the mom is showing you and it looks like a tremor. So how do you tell the difference, right? Now, tremors stop when you hold them. The kid has a tremor. You put your hand on it, it'll stop. And you're done. Then you know it's a tremor. Okay? Tremors are fast in both directions. You'll see the kid's hands come like this. That's a tremor. All right? Seizures, on the other hand, will have a facial component along with the extremity movements. The other thing with tremors and when you have a seizure is that you're fast and you're slow in the other direction. So you'll see this, okay? So are seizures harmful? That's the big question, right? We see it all the time. And it's not totally clear. That made me crazy. Like, what do you mean? We do all this stuff to stop them, all right? So there is some lab data now, but it's all animal studies in terms of whether seizures are really bad for you, okay? What they're finding is that if you have a history of prolonged seizures or a history of recurrent seizures, then you're going to have detrimental effects on both cognition and behavior, all right? And again, these are all animal studies right now. There are some adult brain studies where they've looked at cadavers of people who have a seizure history, and they have found some neuronal death, usually in the hippocampus and stuff like that. So that's the whole point, is that we want you guys to start treating these, and don't wait. So you want to treat them early. All right, LPs. The use of LPs. These guys looked at LPs in afebrile infants who came in with the new onset of seizures, okay? Prospective analysis, they did it nice because these are all neurologists, these are their consults. They looked at the seizures. They looked at the group of 1 to 6 months old, and all these kids were afebrile, okay? So a little more than half got an LP, and they all got, the ones that got the LP, they followed the cultures, both bacterial and viral cultures. The younger patients got LPs at twice the rate, but that's what we would do anyway, right? Abnormal CSF is any CSF with a white count of white count of 6 or more. No confirmed bacterial meningitis in any of those kids, okay? So we feel better, like, all right, maybe I don't have to do an LP. Problems with their study was the small size, and they missed a lot of the viral cultures, okay? Now, meningitis is a common cause of convulsive status with fever. Now, these guys looked at seizures for more than 30 minutes and fever. What they found really simply was the prolonged seizures with fever, their meningitis rate was between 15 and 18% versus a prolonged seizure without fever. Those guys got up to 1.2% had meningitis. So if it's a prolonged seizure with fever, do the LP. All right? You always got to do your gut check, okay? If you're thinking about it, you're worried, and you're thinking about meningitis, just treat and do your LP. Quickly, febrile seizures. What's my time? All right, febrile seizures, really quick. This is the biggest group you're going to see in ED, okay? It's over 100,000 of them, less than 5, okay, of 120,000 total. Okay, this is the group you'll see. Of course, you're going to have a fever, and this group is between 6 and 60 months old, all right? You can't call it a febrile seizure if they have other issues like cerebral infection, metabolic derangements, epilepsy. 2 categories of febrile seizure, of course, are your simple. They're going to be less than 15 minutes. They're usually generalized, tonic-clonic. They're once in 24 hours. Complex, of course, is going to be 15 minutes or longer, usually. They're usually more focal. And they're going to have more than 1 seizure in 24 hours. Okay? Does this have any adverse effects? No, their IQ is fine, okay? There's no evidence that these kids have any issues. In terms of epilepsy, we'll go real quick. They have the same rate of epilepsy until age 7 for everyone else. And then after that, it can double to 2.4%. Everyone sitting here had about a rate of about 1% for epilepsy. Recurrent, yes, all right? It's gonna happen again. Tell the parents that. You've gotta let them know. If the kid had it before his first year, he has a 50% chance of having it again. And if he has it after the first year, he has a 30% chance. So really let the parents know. All right? Does anyone die from this? And I looked everywhere for this, and no. Okay? They usually don't die unless we do something wrong. Should you CT them? Really simply, if it's a simple febrile seizure, don't do it. Complex, you could think about it, especially if it's prolonged and you're worried about other things. Treatment and prevention. Anticonvulsants, both intermittent and continuous, are not recommended. And the reason is simple. The side effects from the drug are worse than the febrile seizures, so don't do anything. Do the antipyretics work? They don't work either, but we give the parents something to do, keeps them happy, but they don't work, okay? So in summary, neonatal seizures are subtle. Consider midazolam intranasally, especially when you have a shaking kid you can't get an IV in. Do the LP for fever and status, okay? Febrile seizures, simple, do nothing, okay? For complex, you want to do a workup, and you want to educate your parents so they don't keep coming back, all right? Thanks.